Good morning, friends. Welcome to Dr. PM Times. This is Dr. Murugesan. In this episode, we will be discussing about the problems faced by the obese people. So, one common problem faced by obese people is gastroesophageal reflux disorder, which is also known as heartburn. It is so common that it affects almost 15 to 20% of adults, and it is even more in case of obese people. Now, what is this gastroesophageal reflux disorder? As the name suggests, it is a disease that occurs due to, or it is a group of symptoms that occur due to reflux of the acid content of stomach into the lower end of esophagus, which erodes the mucosa of lower end of esophagus, causing a lot of signs and symptoms. It causes various signs and symptoms, but everything is grouped under one term, gastroesophageal reflux disorder, commonly known as heartburn. Now, what is the cause for this? As I said, it is due to the acid content of stomach eroding the lower end of esophagus. Normally, acid has to remain in stomach. The stomach is provided with a lot of protective mechanisms which are called gastric mucosal barrier, which prevents the acid pepsin digestion of gastric mucosa. So it doesn't erode, the acid doesn't erode the gastric mucosa. Whereas the lower end of esophagus is not provided with these barrier mechanisms. So it makes it vulnerable once acid pepsin mixture passes through the gastroesophageal junction and goes and acts on the lower end of esophagus. But normally it doesn't happen. Nature has provided various protective reflexes or mechanisms by which the acid secreted by stomach is prevented going anti-gravity wise and acting on the lower end of the esophagus. Now, what are the natural protective mechanism against the acid pepsin digestion of lower end of esophagus? Number one, when we move around, the force of gravity itself doesn't allow the antiperistaltic activity. So, food that we swallow naturally has to go down and the content should keep going down. There is no chance for the content in the stomach entering into the esophagus. So, force of gravity aids, number one. Number two, food that we swallow passes through the esophagus, and food, once it enters the esophagus, is swept cleanly and thoroughly, quickly into the stomach by two peristaltic waves, primary and secondary peristaltic waves. And by the movement of this esophagus, the food passes into the stomach quickly. Then there is no antiperistaltic wave. So there is no chance for food in the stomach entering into the esophagus. Then along with food, we also swallow the contents of saliva. And one important content of saliva is sodium bicarbonate, which is an alkali, which neutralizes whatever little acid accidentally entering into the lower end of esophagus from the stomach through the esophagogastric junction. So it neutralizes. Then the lower end of esophagus, there is a protective sphincter called lower esophageal sphincter, which allows only one-way movement. Food from the esophagus can enter into the stomach, whereas food entered into the stomach cannot get back into the lower end of esophagus. Also, a part of esophagus is intra-abdominal, and this intra-abdominal part closes like a flap valve once the intra-abdominal pressure rises, and that also prevents the food from the stomach to enter into the lower end of esophagus. Also, the gastroesophageal junction mucosa has numerous folds. They are called Rosatom mucosal folds. These mucosal folds also close and prevent the stomach content from entering into the lower end of esophagus. Then, in the esophagogastric junction, there is a separation called diaphragm, which is an important muscle which separates the two cavities, the thoracic cavity above and the abdominal cavity below. And this diaphragm prevents the reflex by acting as a pinch cock. The coronal diaphragm acts as a pinch cock, and the stomach contents cannot enter into the esophagus. So the esophagus should remain in the thoracic part and stomach should remain in the abdominal part, and they should be separated by a diaphragm, and the diaphragm acts as a pinch cock, preventing the contents from stomach to enter into the esophagus. So all these protective reflexes prevent the contents of stomach from entering into the esophagus. Also, the stomach keeps emptying its content once it receives it into the duodenum and intestines further by its own gastric pump activity. And this unimpeded gastric emptying also prevents the food from entering. Food means acid mixed food from entering into the lower end of the esophagus. I've already told the problem starts only when the acid pepsin mixture erodes the lower end of the esophagus. Now, what happens in obese? In obese, all these protective reflexes are lost. Because they are obese, the muscularity is less and adipose tissue is more, the muscles are weak. So, what happens because of that? The diaphragm is weak. So, the pinch cock action of diaphragm is lost and food can now easily enter, that is acid pepsin mixture can easily enter from the stomach into the lower end of esophagus, making them prone for gastroesophageal reflex. Then also in obese, the intra-abdominal pressure is more and because of the intra-abdominal pressure, increased intra-abdominal pressure, again food can easily enter into the esophagus. Then the obese have a tendency of binge eating and going to bed immediately after consuming food. This prevents the gravity from acting and making them prone for gastroesophageal. That is why they get frequent belchings at night, heartburn at night, they get disturbed sleep. Then what happens? The gastric pump activity, gastric emptying is also delayed. Food remains in the stomach for a long time, so making them prone for gastroesophageal reflex. Then also in obese, the lower esophageal sphincter also is defective. The sphincter tone relaxes, allowing the acid content of stomach to enter the esophagus, cause erosion and causing this problem. So that is why this gastroesophageal reflux disorder is very, very common in obese. Apart from that, the obese also have a problem called hiatus hernia. I've already told you the thoracic cavity is different, abdominal cavity is different, and they are separated by diaphragm. In the abdomen lies the stomach, in the thorax lies the esophagus. And in obese, what happens? The opening in the diaphragm through which esophagus connects with the stomach is called hiatus. This hiatus becomes weak, so a part of the stomach and the esophagogastric junction can pass through this hiatus and become an intrathoracic part. Stomach is always an intra-abdominal part. So when the opening is weak in obese, it rarely a part of stomach or upper part of stomach alone becomes an intrathoracic part, which is called hiatus hernia. So what happens? The acid pepsin action is facilitated once the intra-abdominal part of stomach becomes an intrathoracic part. So all these protective reflexes which are normally present is lost in an obese, making them prone for acid pepsin erosion of the flimsy or vulnerable lower end of esophagus, making them prone to this disorder which is called gastroesophageal reflux disorder. Now, what is the problem? What happens when gastroesophageal reflux disorder occurs? First, as acid enters into the lower end of esophagus, it erodes and causes esophagitis. They get frequent belching, a feeling of fullness always. Then the acid can even go even up to the larynx. Reflux can occur even up to the larynx, causing laryngitis, resulting in hoarseness of voice. Sometimes the acid can enter into the respiratory tract even, leading to bronchitis. This will lead to chronic cough. So one of the cause for a chronic cough is this gastroesophageal reflux disorder. We should have it in mind when a person comes with chronic cough, especially obese. He also complains of frequent belching. We should think of they may have a reflux which has entered into the respiratory tract causing bronchitis, and so the cough is not suppressed with the antibiotics, antihistamines, cough syrup, whatever you go give, the cough doesn't get suppressed. But you give a proton pump inhibitor, say omeprazole, the person is very much relieved. So such much common is chronic cough in this reflux. Then this retrosternal discomfort caused due to the reflux esophagitis can even mimic a chest pain. They may have chest pain like symptoms. So you should not think of myocardial infarction and angina always when there is retrosternal discomfort. We should think of common things first. This is very common, even more common. So think of this first. Then you think of the rarer or less common things. Then they may even complain of dysphagia or difficulty in swallowing. And because of this chronic reflux, they can develop dental erosions and they can even end in chronic bronchial asthma. So all these are various signs and symptoms of a person suffering from gastroesophageal reflux disorder. Now, how to alleviate this problem? How to overcome this problem? For simple lifestyle measures, tell the patient to avoid foodstuffs which are irritating, foodstuffs which prevent the sphincter tone of lower esophagus, say chocolates, alcohol, cheese, etc., can relax the lower esophageal sphincter. The sphincter tone is lost when you indulge in too much of alcohol or fatty diet, so making them prone for reflux esophagitis. So avoid such foods which relax the lower esophageal sphincter. Also avoid citrus fruits which can irritate the esophageal and also even gastric mucosa. Citrus fruits like lemon, oranges in people suffering from gastroesophageal reflux. Then stop smoking, very, very important. Do not involve in binge eating. Always limit your food intake to half full or 3/4 stomach. Then early dinner is the key. Take dinner before 8 p.m. at least. Earlier is better. Then go to bed at least 1 hour after having food. Indulge even in walking for 30 to 40 minutes before retiring to bed. That means because of gravity, the food has passed the esophageal gastric junction, reaches the stomach, and it even can move down easily, so that there is no chance for reflux in them. Then here obesity is the common precipitating cause. So avoid overweight. Maintain ideal body weight. Maintaining ideal body weight is the key. Then, of course, physical methods such as elevating the head end of bed while lying down may give them some alleviation of symptoms, especially they suffer from sleep apnea at night. They have difficulty in breathing when they go in for deep sleep. They have to, because of this reflux, they have to wake up, go near the window, take 2-3 breaths of air, then lie down. In such patients who are suffering from sleep apnea and frequent belching, head and elevation will be very, very helpful to them. Then after all these lifestyle modifications, also prescribe them drugs such as PPI inhibitors and domperidone. These drugs are commonly available now as omeprazole, pantoprazole, rabeprazole, etc., along with domperidone, which they take for a long duration, which act as a prokinetic and plus suppress the acid secretion, gives them lot of relief to such patients. So maintain ideal body weight. Early dinner, walk at least for 45 minutes after dinner. Don't indulge in fatty foods, alcohol, smoke, chocolates. Avoid irritating foods such as citrus fruits. Then lie down with head and elevation. All these measures will give lot of relief to patients suffering from gastroesophageal reflux disorder. Thank you. In this episode, we are going to discuss about another common problem, very, very prevalent in obese, which is called systemic hypertension or elevated blood pressure. Now, what is hypertension? Hypertension is a recording of, it's a persistent recording of elevated blood pressure with respect to the age, sex, and build of the individual, because it will vary with age, sex, and build. So you should not look into one value alone and decide that he is hypertensive. As I said, it is a persistent recording of elevated blood pressure over a period of time. And you should also consider the age of the person, sex of the person, and build of the person before concluding that he is a hypertensive. Now, before going on to the actual problem, I just want to tell a few words about the basics of blood pressure. Now, we should know what is blood pressure. Blood pressure is nothing but a lateral pressure exerted by blood column along the walls of the blood vessel. The blood vessel has got blood, the blood is streaming, it is flowing, and while flowing, the flow is usually smooth, and while flowing, it exerts a pressure along the walls, a lateral pressure. And this we record it over by tying a cuff, connecting it to a mercury manometer, which is called sphygmomanometer, and the pressure exerted by the blood column is transmitted and recorded by the elevated mercury column, which we note it down. So two pressures we usually note. One is systolic pressure, other is a diastolic pressure. Now what is this systolic pressure? Systolic pressure is the maximal recordable pressure during a cardiac cycle. Cardiac cycle means a heart will beat once in 0.8 seconds and will undergo a cycle of events. And in this cycle, the maximum pressure that is recorded is called systolic pressure, and it depends on the force of contraction of the ventricles, otherwise known as cardiac output. The main function of heart is to pump blood. So the force of contraction determines the maximum pressure that is recorded, which is called systolic pressure. Another pressure that is recorded is called diastolic pressure. It is the opposite. It is the minimum pressure that is recorded during a cardiac cycle. The normal systolic pressure is usually around 120 millimeters of mercury, and normal diastolic pressure is usually around 80 millimeters of mercury. The unit is always in millimeters of mercury because it is the level of elevation of mercury that we watch and record it. The difference between these two pressures, systolic and diastolic pressure, is called pulse pressure. So normally the systolic pressure is 120 and the diastolic pressure is 80. The pulse pressure is 40. And it is the pulse pressure that determines the pulsatile nature of blood flow. Blood flow is pulsatile. It is forceful sometimes, it is less forceful sometimes. So this pulse, that is what we feel as pulse. So this pulsatile nature of blood flow determines the pulse pressure, which is usually more in the case of adults, especially in elderly. In very old people, the pulse pressure is more, the difference is more. They have a high systolic pressure, physiologically normally, and low diastolic pressure. So the difference is naturally more, pulse pressure is more in case of elderly. Now I said systolic pressure is an indicator of force of contraction of the ventricles, how your heart pumps. Now what does this diastolic pressure indicate? Diastolic pressure indicates the resistance against which the blood flows. The resistance offered by what? The blood vessel. This is called peripheral resistance. So the resistance against which the blood flows determines the diastolic pressure. Systolic pressure usually has a lot of physiological variations. It varies with age, it varies with sex, it varies with build of individuals, it varies with the physical activity, it varies with the emotional status, it varies whether you have taken food and recording blood pressure, it decreases during sleep. So there are a lot of physiological variations in systolic pressure. So an elevated systolic pressure is not as significant. It is significant, but you should consider the physiological variations also. Whereas diastolic pressure does not have such physiological variations. So what I want to emphasize is in the first recording, if you see an elevated diastolic pressure, you should be more concerned than seeing a systolic pressure elevation, because systolic pressure can elevate when you see the doctor for the first time and you record BP. All of us must have experienced. You go to a clinic, the doctor with the white coat sits there with grim face and he stares at you, he ties the cuff, he raises the mercury column. In your anxiety, you see the mercury level rising. As the mercury level rises and you keep watching it, your blood pressure also rises, which is called white coat hypertension, which is common and normal in most of the individuals. And just one recording of elevated systolic pressure, you should not brand him you are hypertensive and start prescribing medicines. So you should consider all these facts before concluding a person has got elevated blood pressure or not. So what I want to emphasize here is an elevated first time recorded diastolic pressure is much more significant than an elevated first time recorded systolic pressure. Then as I said, the blood pressure has various physiological variations. So before declaring a patient hypertensive, record the blood pressure in a proper way. How to properly record the blood pressure? Blood pressure is recorded properly. Once the patient comes to the clinic, the doctor should make him relaxed, make him sit in a chair with the arms on the sides without crossing like this. The legs also should not be crossed. You should preferably sit with the backrest. Then the pressure is recorded in the non-dominant arm. If he is a right-handed individual, record in the left hand with the cuff occupying at least 3/4 the size of the arm. Then talk to him, make him relax. Don't record immediately. At least 15 minutes after he sits down. Once he is at physical state of rest, mental state of rest, at least 2 to 3 hours after having his last food, once he calms down, relaxed, sitting with backrest, with the legs not crossed, arms not crossed. Now you record. You make him at ease and then record. That is the best way to record blood pressure. The cuff size should be proper, and the apparatus, the cuff and the heart should be at the same level. Apparatus should not be kept at higher level. He should not be seated low. So he should be seated at the same level, then record. This recording is called basal blood pressure. So an ideal blood pressure recorded in this way is called basal blood pressure. Then you take another reading 2 minutes after that. In both the readings show an elevated blood pressure. Then only you record or diagnose this case as a hypertension. Otherwise, don't be hurry to conclude that he is hypertensive. So make him relax, then take at least 2 readings. Both readings are elevated, then only he is declared a hypertension. Now, what is the value to declare a person hypertensive? As I said, in a normal 70 kg adult male who is between 20 to 30 years of age, everything is important. The normal blood pressure is 120 millimeters systolic and 80 millimeters diastolic. In such an individual, if the blood pressure elevates from 120, say 130, say 130 to 139 systolic is recorded, and diastolic say 90 to 100 is recorded, he is declared pre-hypertensive. It's not hypertensive, it's pre-hypertensive. If the recording is above 140 millimeters of mercury systolic, if the systolic pressure is recorded more than or equal to 140 to 149 millimeters of mercury, and diastolic pressure is recorded more than or equal to 100 to 110 millimeters of mercury, then he is declared hypertensive. If the recording is very high, say systolic pressure more than or equal to 180 millimeters of mercury and diastolic pressure more than or equal to 120 millimeters of mercury, then it is called very severe hypertension or malignant hypertension. It is an emergency. He has to be corrected immediately, or else he is more prone for stroke or ischemia. So such values you should have that background. You consider the age of the patient, sex of the patient, build of the patient, his physical activity before declaring a person hypertensive. Now, what is the problem if he is hypertensive? Let there be an elevated blood pressure. Elevated blood pressure affects all the systems of the body. A persistent recording of even mild elevated blood pressure, say 130 to 90, 130 bar 90 millimeters of mercury in a 30-year-old, if he is recording it persistently over years, it can cause long-standing problems or problems affecting the blood vessels, mainly the heart, the kidney and the brain, which is called, they are prone for coronary heart disease, they are prone for stroke, they are prone for even end-stage renal disorder. So you should be very careful if a person continuously records an elevated blood pressure with respect to his age and sex over a long, immediately try to correct it and bring it back to normal. Now, is there any use for blood pressure? Normally, is there any use for blood pressure? A normal blood pressure is very, very essential for perfusion or blood flow to be maintained through all the tissues of the body, number one. Number two, the normal blood pressure provides the filtration pressure at the level of glomerulus in the formation of glomerular filtrate, which is the first step in the formation of urine. To tell in simple words, for the formation of urine, blood pressure is required. For the nutrients and gases to reach, respiratory gases to reach all the cells and tissues of the body, the perfusion pressure or blood pressure is required. Also, blood pressure is required in the formation of a third space fluid called lymph, which is essential for various activities. So, for all these purposes, blood pressure is required. So, normally we require blood pressure. Only if it is elevated, it becomes problem. So, try to correct it, bring it back to normal as early as possible. And simple lifestyle measures such as maintaining ideal body weight, aerobic physical activity for at least 30 minutes a day for 5 days a week, a low salt intake, going to bed at proper time, sleeping for at least 7 hours a day. See to that in sleep, you should sleep more before 12 midnight. The sleep of 1 hour before midnight is equivalent to 2 to 3 hours of sleep after midnight. Have that in mind. So a good sleep is very, very essential. Only people who are sleep deprived, who are working at night shift workers are more prone for this elevated blood pressure. So a proper sleep, proper exercise, proper weight, low salt diet, low fat diet, all these are key in lifestyle modifications in keeping the blood pressure under control, because most common cause for blood pressure is it's called essential hypertension, where there is no specific primary cause. It is our lifestyle induced problems which can make the person hypertensive. Only 5% of individuals there is a known primary cause. That is, they will have some other disease, say a renal arterial stenosis. A problem in the blood vessel supply the kidney can cause hypertension. But it is rare. It is present only in less than 5% of cases. 95% of cases, hypertension is only essential hypertension, where there is no primary cause. Sometimes genetic factors can play a role. Say Asian Indians, hypertension is common because genetically they are more prone. Other than that, there is no primary cause for hypertension. Most of it is called essential hypertension. So by simple lifestyle measures, by maintaining proper diet, proper exercise, having good sleep pattern can prevent a person from becoming a hypertensive. Thank you. In this episode, I am going to focus on another common problem faced by the obese, which is called fatty liver, which is very, very common nowadays. You don't know that you are having a fatty liver, which is common, especially in Indians who indulge in carbohydrate based diet. So they go for a routine ultrasound. Accidentally, they come with the finding they have grade 1 fatty liver, grade 2 fatty liver. So they get panicked and immediately consult a physician. What is this? So nothing to panic here. Simple steps can prevent or make you get back to even from grade 3 fatty liver to normal liver. So my idea is to focus on what is fatty liver first, what causes fatty liver, how it progresses. Then I will tell the remedial steps also. Fatty liver, as like any other metabolic disease, is common in obese. It is a manifestation of metabolic syndrome. People with metabolic syndrome or insulin resistance are prone to have this fatty liver. Obese people who have all the symptoms or signs of insulin resistance, who have all the criteria for metabolic syndrome, fatty liver is the common presentation. It is as common as 60 to 70% incidence in obese compared to just 20 to 30% in normal. So it's very, very common in obese or overweight individuals. Now, what causes fatty liver? Fatty liver is due to excess triglyceride deposition in the liver cells. As you all know, when you take food, we observe glucose, and this glucose is used as a source of energy after food. Whereas in between meals, when food is not available, fatty acids are used as the main source of energy. What we do is we take more than what is required, and this excess glucose is stored as triglyceride in the adipose tissue. The triglycerides get broken down in the adipose tissue, converted into fatty acid, and they are taken to the liver. So the excess fatty acid load to the liver getting deposited in the liver cells, which are called hepatocytes, leads to fatty liver. Number two, the excess fatty acid derived from the excess glucose that we take because of a shunt pathway called HMP shunt. The excess glucose first converted to glycogen, more the glucose that we take is converted into fatty acid. So the excess fatty acid derived from glucose that we take as carbohydrate also get deposited in the liver. These triglycerides are meant to be stored only in the adipose tissue. Only the adipose tissue is capable of handling these triglycerides well. The excess triglycerides from the adipocytes get spilled over, then it goes for storage in the liver cells, which are not professionally capable of handling these triglycerides. It is the fatty acid that is stored as triglyceride. So, because of accumulation of triglyceride in the liver cells, this problem of fatty liver occurs. Also, the liver cells is not able to oxidize the excess fatty acid that is accumulating due to the toxins released from adipose tissue. In truncal obesity, what happens? The adipose tissue releases a lot of toxins called adipocytokines, especially tumor necrosis factor alpha, a substance. This toxin can act on the liver cells and they impair the liver cell activity of oxidation of fatty acid that reaches the liver cell. So there occurs a two problem. Excess fatty acid is now mobilized from the adipose tissue to the liver cell, number one. Number two, the fatty acid that is mobilized cannot be oxidized by the liver cell because of the toxin that is also released by the adipocyte. So more fatty acid reaches, less fatty acid is oxidized, leading to fatty acid accumulation in the form of triglyceride in the liver cell, which in due course becomes what is called fatty liver. It is commonly known as non-alcoholic fatty liver disease because it affects even the non-alcoholics. So don't say that I am not taking alcohol, I am not smoking, why I am getting problem in the liver. Doesn't mean only alcoholics can get the liver problem. Even a person who is non-alcoholic, not smoking, but he indulges in excess carbohydrate intake, he is obese, can have this fatty liver. So what happens because of this fat accumulation? So first, as I said, he develops fatty liver. Then as a course of time, he develops inflammation. The inflammation is due to the oxidation stress induced by fatty acid. It is also due to the gut-derived endotoxin. It is also due to the adipocytokines released from the adipocytes. All these can cause inflammation. So they go on to the next stage, which is called non-alcoholic steatohepatitis. First, it is called steatosis. Just accumulation of fat is called steatosis. Once they develop inflammation, it is called steatohepatitis, which is the next stage. Then they cause, they end up in even liver cirrhosis. It is due to the damage of the liver cells being replaced by fibrous tissue. Once the liver cell is damaged, it becomes replaced by fibrous tissue. Excess fibrous tissue as a repair of fatty acid damage of the liver cell can lead on to liver cirrhosis. Liver cirrhosis is an irreversible problem. Fatty liver is very much reversible. Non-alcoholic steatohepatitis, the next stage, the inflammatory stage, also you can easily reverse. Whereas once the person enters into the cirrhotic stage, when fibrous tissue replaces the normal liver cell, it becomes irreversible, very difficult to correct after that. And rarely few patients can even end up in liver malignancy, which is dreaded, which is fatal. So that is why we have to focus on early correction of fatty liver grade 1, grade 2, grade 3 to normal liver. How to do it? As I said, the person suffering from fatty liver doesn't have any severe signs or symptoms. He is normal, he is obese, truncal obesity is present. He has a habit of indulging in carbohydrate diet predominantly. He takes intake is more and his expenditure is less, doesn't have any physical activity, he doesn't have any much of muscularity. So such individuals we should suspect of fatty liver. It is an incidental finding. He doesn't have any symptoms. He doesn't have much complaints initially. Grade 1, grade 2, he doesn't have any complaints. He is absolutely normal, moving around. Only thing is obese. Rarely he can have a right upper quadrant discomfort. That is where the liver is situated. Otherwise, he is not. So such persons, you do an ultrasonogram as an incidental finding. When you do it for some other ailments, usually we diagnose grade 1 or grade 2 fatty liver. Then how to, once a person comes with the ultrasonogram, he becomes panic and he comes to you. Then you have to intervene at that time. Simple corrective measures can reverse fatty liver even back to normal liver within say 3 to 6 months period, because the liver cell tissue has high regenerative capacity. It can repair and get back to normal easily. As we discussed, we understand that fatty liver is common, especially in South Indians who are mostly carbohydrate based diet. So, how to reverse this problem of fatty liver, which is so common nowadays, even in non-alcoholic? I said it is a non-alcoholic fatty liver disease. It is very simple. Eat healthy is the key. Avoid refined carbohydrates. Take complex carbohydrates which are fiber rich. Avoid frank sugars or added sugars, the sugar that you add in tea, coffee. Avoid sugary beverages. Reduce the saturated fat and trans fat intake, which is common in bakery foods, packaged foods, processed foods, animal foods such as cheese, butter, etc. As much as possible, avoid this. So, if you do this, further damage or progression can be prevented. Then, how to reverse this? It can be easily reversed by replacing the food with the superfoods. Take superfoods as much as possible. The important superfoods I would like to mention is, number one is garlic. Garlic is a potent detoxifier. It helps to reverse fatty liver to normal liver easily. Number two, add as much as cruciferous vegetables, especially broccoli, which are fiber rich, which is helpful to reverse fatty liver back to normal. Number three, use olive oil for cooking, which is also very helpful to reversing. Then number four, intake of fish oils, say cod liver oil, sardine oil, will be very helpful to reverse fatty liver back to normal. Green tea consumption is also helpful. Beetroot is supposed to be a very good superfood and detoxifier, which is rich in nitrates, which is helpful not only for reversing fatty liver, it is also helpful in atherosclerotic coronary vascular disease also. Also, take as much as fruits, especially citrus fruits. Say add lemon and oranges in your day-to-day routine. All these are supposed to have a high regenerative capacity. Liver cell as such has got high regenerative capacity. All these superfoods add to the regenerative capacity so that a person even with grade 3 fatty liver can be easily reversed back to normal liver in a span of say 3 to 4 months. Then indulge in aerobic exercise activity of at least 150 minutes per week. Then avoid alcohol. You should stop alcohol. You should quit smoking and don't take unnecessarily the drugs without prescription or consulting a doctor. So by all these basic steps, you can easily revert a person in fatty liver, even grade 3, grade 2, back to normal liver. Thank you. In this episode, I am going to focus on another common problem in South Indians, which is known as metabolic syndrome. Nowadays, you must be familiar with this term, metabolic syndrome. It is very common in obese. It is also known as insulin resistance syndrome or syndrome X. As you said, it is a syndrome. That means it is a complex of features seen in a person make him categorized under this problem, metabolic syndrome. Usually, the person with metabolic syndrome is an obese. He is also having insulin resistance, so he is a diabetic, and he is having dyslipidemia, so he is more prone for atherosclerotic coronary disease. So that is why we are worried. Metabolic syndrome is usually a prelude to diabetes mellitus. A person with metabolic syndrome now can become a diabetic later, established diabetic. A person with metabolic syndrome can develop severe hypertension later. A person with metabolic syndrome can have severe dyslipidemia, atherosclerosis, atherosclerotic coronary vascular disease or coronary heart disease, are commonly known as heart attack later, which is dreaded, which is very common nowadays. So it's a dreaded combo: elevated blood pressure, uncontrolled hypertension, uncontrolled blood sugar level, and coronary vascular disease. All these are a dreaded combo. So there is no point in correcting once he becomes an established diabetic hypertensive or he has already suffered from coronary heart disease. Instead, you should identify, correct it at the metabolic syndrome stage itself so that you can prevent him from ending up with say either end stage renal disease or coronary heart disease or even stroke. So how to identify early? or what is the criteria for classifying a person metabolic syndrome, that he is having metabolic syndrome. So the criteria is, as I said, he is usually obese. So a person with the body mass index more than at least 25, number one. Number two, his waist circumference. If the waist circumference is more than or equal to 90 centimeters in a male or 82 centimeters in a female, he is at a risk of being categorized as metabolic syndrome. Then his blood sugar level, if his fasting blood sugar level is more than or equal to 110 milligrams per deciliter, and his lipids, especially triglycerides, more than or equal to 150 milligrams per deciliter, then genetic factor, if he is a South Indian, then who is indulging in more of carbohydrate diet. So all these factors make him classify as a person suffering from metabolic syndrome. Also, if you record the blood pressure in this subject, if the blood pressure is more than or equal to 130 systolic and 85 diastolic, he is categorized to be under metabolic syndrome. So, a person with BMI more than 25, increased triglyceride more than or equal to 150, blood sugar level more than or equal to 110 milligrams per deciliter, waist circumference of more than 90 in male, and he is an overweight, he is a South Indian, then naturally he is categorized as metabolic syndrome. So you should be cautious at this stage itself. You can see from this criteria, it is common among all who we see above 40 years in our clinic. A person who comes to your clinic, a 40-year-old South Indian, genetically he has got a 20% risk of developing a metabolic syndrome. Number two, if he is overweight, another 20% adds on to that. Then his waist circumference is more than 90. Maintaining a waist circumference less than 90 in a male is very, very difficult. All of us know. You just take a tape and measure the midpoint between anterior superior iliac spine and the lower end of rib at the level of umbilicus or just below the umbilicus, and you see it is very difficult in a 40-year-old or more men to maintain it less than 90 centimeters. So metabolic syndrome is very, very common in South Indians nowadays. So you catch them at that stage itself, start treating them, prescribing them healthy diet and healthy exercise pattern. Once they do that, you can preventing them from becoming an established hypertensive, established diabetic or established coronary heart disease patient later on. Advise them low salt intake, low carbohydrate intake, low fat intake, quit smoking, stop alcohol, aerobic exercise activity of at least 150 minutes a day, a good sleep pattern of at least 7 hours a day, avoid unnecessary stress, then eat a healthy, balanced diet with more of protein and less of refined carbohydrates. All these can prevent a person categorized as metabolic syndrome from becoming an established diabetic or coronary heart disease patient later. Thank you. In this episode, I'm going to focus on another common problem faced by the obese people, that is dyslipidemia or altered lipid level in the blood. First, we will see what is the normal lipid. Normal fat lipid or fat content in the body is 400 to 600 milligrams per deciliter. It is available in various forms, and there are three major forms. 40% of it is in the form of cholesterol, 30% is in the form of phospholipids, and 20% is in the form of triglyceride. These lipids or body fat are usually water insoluble. So to be transported in the blood, they have to be combined with a protein, and together they are called as lipoproteins. So they are transported as lipoproteins, and they are separated by centrifugation, and according to the density, the less dense, more fat containing substances go to the top. They are called as very low density lipoproteins or low density lipoproteins. The more dense or less fat containing or more protein containing fat go to the bottom, which is called high density lipoprotein. High density lipoprotein means they contain low fat and more protein. Low density lipoprotein means they contain more fat and less protein float in the system. So they go to the top. So the cholesterol is a waxy substance which is present in all the essential for cell wall, it is essential for synthesis of vitamin D, it is essential for synthesis of various hormones. And this cholesterol is produced mostly in the liver and almost all nucleated cells, and it is excreted via the liver and enterocytes. These lipids, after centrifugation, is categorized into 5 types. Number 1 is chylomicron. Number 2 is low density lipoproteins. Number 3 is intermediate density lipoproteins. Number 4 is very low density lipoproteins. Number 5 is high density lipoproteins. The level of all these substances you should know before categorizing a person as dyslipidemic or not. The National Cholesterol Eradication Program guidelines before declaring a person dyslipidemic is a level of less than 200 milligrams per deciliter of total cholesterol is supposed to be desirable, and level of more than or equal to 240 milligrams per deciliter of total cholesterol is supposed to be harmful. In case of LDL, a level of less than or equal to 100 milligram per deciliter is supposed to be desirable, and an LDL level of more than 120 milligrams per deciliter is supposed to be harmful. An HDL level of less than 40 is supposed to be harmful. Remember, HDL is good cholesterol, lesser HDL level is harmful. So less than 40 milligrams per deciliter is supposed to be harmful, and a level of more than or equal to 60 milligrams per deciliter is supposed to be desirable. Though in Indians a level of more than or equal to 60 is very rare, more than or equal to 50 milligrams per deciliter even is desirable. In case of triglycerides, a level of less than or equal to 150 milligrams per deciliter is supposed to be desirable, and a level of more than or equal to 200 milligrams per deciliter is supposed to be harmful. So the key points is an LDL level should be kept below less than 100, total cholesterol level should be kept below 200, triglyceride level should be kept below 150, and HDL level should be kept above 50 milligrams per deciliter to declare a person's lipid profile is normal. If it gets altered, if any of these changes, if there is more LDL level, if there is more total cholesterol level, less HDL level, supposed to be dyslipidemic. Thank you.